Hey guys, how's it going? Usually we start these, just by starting, and then we put in the descriptor who the person we're talking to is. But I think in this case, I want to talk about John, who we're speaking to today, Dr. Saratsiotis, because I think his background does play well into the topic that we're discussing. In other words, there's some speciality or specialty, I should say, that John brings to this table. So John, besides being one of my closest friends for a long time now, is very long time, too long actually, well, not too long in that we're getting old. That's what I meant. I don't mean that I want to end the friendship due to any other circumstances. Right. But anyway, John is a physiotherapist as well as a doctor of chiropractic. As well, John majored in biochemistry at McMaster University in his undergrad. Did I sum that up pretty well? That's pretty much all of it.
Yeah, that's pretty good. Yeah.
So John, he's also a published researcher. He has chapters in books pertaining to fascia, pertaining to connective tissue, dynamics, et cetera, et cetera. So besides all that, John's also one of the functional range systems instructors. He's currently residing in Greece and has been for most of his professional career, actually. And the reason why John and I decided to do this conversation is because, for those of you who don't know or who are not manual therapists, if you're trainers here, this is going to be very helpful to you. But if you're a manual therapist, you might be more familiar or closer to the quote unquote controversy that's currently surrounding soft tissue and the idea of what soft tissue is doing, if anything, and the concept as to whether or not there's actually, I would say, a strong argument out in Instagram land. These aren't in any reputable sources, where people will say things like soft tissue is unnecessary, and there's a whole bunch of misunderstandings as to why they're saying that. And really what this boils down to, in my opinion, and John will get your opinion shortly, is a bunch of people throwing the baby out with the bathwater, in that we have a certain amount of research, and with that research you can conceivably make one conclusion which pushes you one way, or you can make another conclusion which pushes you another way. Of course, we're under the on the side that's saying there's more than enough research to demonstrate the efficacy of soft tissue. And it's funny, and I'm sure we'll get into this later, that a lot of these same people who are speaking about how therapy is not useful in terms of soft tissue, they'll often also say, well, we do use some soft tissue therapy. So it's a crazy controversy, in my opinion. But I thought we would go through and go through a technical podcast, which this will be. We're going to go really in depth, and what we're going to cover in this first part, let's call it, because we might do a second part to this, is the concept of fibrosis, and the concept of tissue healing, and the inadequacies of tissue healing, which may lead to the need, or to the I don't know if need is a too strong word, but that would lead to the conclusion that soft tissue therapy might be effective for the patients who have these problems. Did I sum that up? That's pretty much what we want to talk about. I think fibrosis and soft tissue, quote unquote, is the main topic here.
Yeah, that's going to be the topic. I mean, I'm going to kind of from there diverge to other things, but I mean the big thing is going over what the research tells us. And I mean, you kind of hit it on the head there, the nail on the head, by saying that people just kind of look at the abstracts, they look at the conclusions, they just fire off conclusions, and they really sometimes don't look into the article. People claim to be evidence-based. We know now that evidence-based medicine is composed of three things. It's the research is one component of it. Clinical, I'm going to say expertise, not experience, but expertise. And experience falls under the umbrella of expertise, is the second component. And the third component is patient values, which I think most people, and I've talked about this in the past, most people tend to neglect this. Mm-hmm. They tend to just kind of look at the research and what's out there, and they kind of group people into, this person's a supraspinatus tendinopathy, this person's a low back pain problem. They don't really kind of sit and go through a history process and interview the patient. Take a look at, what the patient's values are sometimes.
I think that's a good point that you brought up, because a lot of these same people that we talk about online, it's almost like I would assume if you spoke to them about evidence-based medicine, they might list off the three things that you listed off. However, in the discussions that you see, it seems to only be the first one, whereby they're blindly looking for a randomized controlled trial or some study of the sort, which is gifting them the answer that they're looking for, ignoring those other two categories that are equally as important in evidence-based medicine, especially when pertaining to the clinical care of a human being.
Right.
Yeah.
Don't forget, when you have that person in front of you, patient expectations nowadays, we tend to look at, what the patient expectations are, and we see that many times it's the number one predictor of outcomes.
Absolutely.
So many times, a lot of the stuff that, patient values will kind of decide what the outcome is. And we're gonna, hopefully we're gonna get into outcome measures.
We will.
A little bit, and we'll talk about that. So I think, that's going to be also very important.
I don't want people to get confused, though. I don't want them to think that we're somehow speaking less of our argument that soft tissue is necessary. I want to get into the actual mechanics, the cellular biophysics of force, and how tissues respond to force, and how we can use application of force in order to guide tissue healing, et cetera, et cetera. So I'm not going to fall back on, there's plenty of research that we can go into on the therapeutic value of touch, which is completely outside the hard biomechanical evidence. But we don't need to go into that research to justify soft tissue. It's already justified in that regard, which is why some of these, I don't want to call them scientists, but some of these Twitter scientists will say that I do some soft tissue work, but it's not that important, and they get to the important stuff. Everyone knows, even by being a clinician for a week, when you utilize therapeutic touch, the benefit is quite obvious, and that goes into the second line of research, which you said, clinical expertise, which is often ignored. Now, I will start by saying that I'm fully aware that some of these people online are just trying to get clicks, and there's always the conversation about clickbait and contrarianism. And I know that right now contrarianism is a big thing in society, and people can make a living off of shitting on other people. But we're not going to justify what we're saying based on soft evidence, let's call it. We do want to justify this based on hard evidence, because there's more than enough. I guess I'll start off. I usually don't have a list, but we did put together a list of things we want to talk about. And for the most part, I'm going to pretend we've been speaking about this for, I don't know how many years now, how many years we've been doing this and teaching all over the world. So we've had these conversations. We've read all of the literature. We've dissected the literature. We've had conversations about the literature, which, by the way, is funny. It almost seems like some people online feel that we don't have access to the same literature they do, or that we're missing something. Whereas that's all we do is spend time dissecting. So I'm pretty sure we've read what you've read. You know what I mean? Like I hate to sound arrogant, but if it's out there, we've, between all of the people in our system, we've consumed it and we've digested it. And it's all about the conclusions you make. But before I really pass the question specifically to you, I do want to talk about one concept that's in your wheelhouse, but it's also very much in my wheelhouse, because I've done a lot of study of evolutionary biology. And the one argument that I've seen come up lately is such it requires such a misunderstanding of evolutionary biology, which I almost want to say that the people who say these have never actually studied this topic. And that is this bizarre concept that tissue heals on its own. And I'm gonna try to get into the heads of these people making this argument. The idea is that because we've evolved so much, that we should somehow inherently have the ability to heal tissue following injury without any consequence. And that's just based on, I guess, the amount of time that we've been evolving for. And why this is such a bad concept is it completely misunderstands evolution, in thinking that evolution has a goal in mind.
Mhm.
And the fact of the matter that evolution does not have a goal in mind, it's just based on selective pressures. So it's not like the system is trying to get better at healing soft tissue injuries, nor is a human being a further along in the evolutionary scale because it's going towards an ideal state. For example, bipedalism, the idea that bipedalism was bringing us towards an ideal state is incorrect, because it's just the state that we got based on the circumstances that were playing out in the natural selective process. So the idea that our tissue healing is so optimized at this point that we don't need to help it at all really negates, I would say, 99% of research that has come out historically on soft tissue injury. And you might want to speak to that too, but it's not like there's a paucity of research on problems that occur post-surgery for supraspinatus tears, or how supraspinatus tears heal on their own, or there's so much like clinical as well as cellular research on what happens to tissue when it's left to its own accord in regard to tissue healing. So maybe you want to speak about that and the idea that this is not ideal in any sense of the word.
It isn't ideal. I mean, if you take a look at the research, and I mean, this, we see this throughout the years, that one of the best ways to get tissue to adapt is to load it. And tissue responds to loading and mechanical loading, and loading, in specific directions, and specific amounts and volume, and how intense the load is. That's all has to be done in a progressive way in order to change what that tissue is going to look like.
Mm-hmm.
The research studies show if you just let that tissue just sit there, it's not going to change. So what you're going to do is you're going to get a lot of connective tissue, and we're going to get into fibrosis probably later in the conversation. So you get more connective tissue laid down, but it doesn't get laid down in a way that's going to help that tissue become better.
Mm-hmm. Mm-hmm. It's really laying it down in a way to patchwork the problem to be dealt with at a later date, which makes perfect sense from the evolutionary standpoint. And one thing that I like to explain to people is conceivably the ways to improve your chances of avoiding injury would have been under higher selective pressure than ways to heal injuries once injuries occur. And that's just how evolution works, because once something gets injured, of course, the chances of that creature not going forward in life goes higher. So a lot of that selective pressure would have been gone, because once injuries occur, it makes you vulnerable to further injuries. Whereas if there was something, for example, that would improve your chances of winning in combat, let's say that you had a sharper talon, or let's say that you were able to be bipedal for a longer period of time during combat to use your arms, or the larger animal, or the bigger teeth. So the things that would help you in the, in hurting or in damaging other animals would have been under higher selective pressure than the ability to heal, because the ability to heal happens over a period of time, or it doesn't happen at all. And I hope that people understand that concept, that the selective pressure will be higher on the other side. So with regards to tissue healing, if you look at tissue healing as a whole, what you see is, yes, it's an amazing system. It's able to heal a lot of soft tissue injury. And if you look across species, a lot of species have this ability. However, the quality of the tissue which is provided in absence of directed measures to improve healing, you realize that it's really piss poor quality tissue. And we're going to get into that, this idea that when things heal on their own, they don't necessarily heal optimally. And I think this is a good time to bring in, there's a evolutionary biologist by the name of Paul Braderman, and he says, I'm going to read this quote: "Evolution has nothing to do with progress. Most evolution doesn't have anything to do with adaptation, and is perfectly possible for a change that is worse than useless to spread through a population." Now that tells us that the evolutionary process has no goal in mind, and it really just deals with the environmental pressures that are put on it at that time. And oftentimes these environmental pressures might lead to the selection of something which is suboptimal in the grand scheme of things, but it might have been optimal in that particular area of time or place in time in order to allow that species to continue. So it really is a general misunderstanding to think that evolution had a goal and that somehow we're working towards this optimal way to heal tissue, because that's just really not how evolution works. And I just wanted to put that out there because it parlays us into the next topic, which I'm going to pass the. Okay, go ahead.
You know what I'm going to say to this is, this reminds me of, a study that kind of people tend to bring up a lot. And the reason why they do this, and if we want to relate this to athletics, there's a study by Wernick that's out there that was a good study on imaging, and it showed that just because there's a high intensity signal on MRI, that's not going to stop a player from returning to play. And we, obviously we do know now that, imaging and structure do not relate always to function.
Absolutely.
The study that, that was done by Wernick, they looked at high intensity signals, and, they looked at the fact that there were athletes that returned to play even with high intensity signals. So based on this, people are saying now, it's one of the conclusions of the article was that because there's fibrosis there, people can return to play. The problem is that the high intensity signal that was shown on MRI, and this was something that the authors themselves noted as far as one of the limitations of the study.
At the end of the article.
At the end of the article.
Most people don't get to, but carry on.
So what the authors themselves noted was the fact that there was acute strains of the hamstrings, grade 1 and grade 2, and what they did was they did PRP injection. So they mentioned the fact that the high intensity signal was actually edema from the injections, and that fibrosis usually is more of a moderate intensity signal. And so if you take a look at what this article concludes, is the authors themselves conclude that the low intensity signals, so the signals that indicate that there's fibrosis, might still be related to an increased re-injury risk.
Right? That's a huge deal, because I've heard this article being thrown around as the reason why it doesn't matter what state your tissues are in, as long as it scars over, but I mean, that's huge, because that admission by the author can actually negate the entire conclusion as it's laid out in the summary at the beginning of the article, which is crazy, right? It's so dangerous to have people skimming literature with a little bit of knowledge. I mean, that really runs into a problem, because a lot of these people, oh, I read the last article I read, that means everything else that I read is garbage. And the same thing happened with stretching, and this to be a fact. There's a little bit of research saying, stretching before injury, not a little bit, quite a bit, stretching before injury stretching before activity doesn't prevent injuries. And then somehow that got translated into there's no need for stretching ever, no matter the circumstance.
Right. We went all the way to the other end.
Yeah. It's like, as soon as something comes out, it just draws people that way, which is, I guess, this clickbait society that we were talking about before, where the coolest thing to put on is something which is either shitting on someone else or putting out a conclusion from an article that makes it seem like everything we learned before that article was somehow negated now.
And it's interesting, because since you mentioned stretching, because I will probably mention this later on when we talk about possibly soft tissue work and how we can possibly affect the fibrotic tissue. There is research showing that stretching does affect fibrosis. So it affects some of the inflammatory agents during fibrosis. So
not to mention that there's some research discussing the idea that stretching might start the process of sarcomerogenesis.
Correct.
Which again is a is part of the healing process. It's part of it, but it's just ignored. But yeah, there again is an example of this tendency to skim articles, and then it's almost, you can look at research in two different ways. I've always said you can either listen to what someone else says and then try to find stuff that shits all over that person's opinion. So you can look at it in a negative light, or you can read the article and kind of put it into this, what does this tell me about the grand scheme of things? You know what I mean? And and that's the difference between how people, I use the example of like the Q angle in your knee. You know what I mean? And there's research that will say, I don't know, I don't remember the exact, but there's research that'll say, in a population of this many people, the increased Q angle, they had an increased Q angle and it did not lead to knee problems in 53% of this population. But that means in the other people it might have. But because the conclusion hits that barrier of no, that becomes the conclusion that is blanketed across everyone all the time. I mean, there's research that demonstrates that having a gut or being overweight doesn't lead to low back pain. But
Right.
if you look at that research in another light, you realize that what they're saying is in the things people studied, it's the percentage. It's just, in this particular study, 51% of the people, it didn't matter. That means in 49% it could. And that's also you're asking the question, is only being overweight the problem? But that's not what anybody's saying.
Right.
And I think, yeah.
Now, there's more research coming out now saying that, since you mentioned obesity, the fact that fatty tissue, you're going to get more inflammation. So those people tend to have, chronic issues with either joint issues or soft tissue problems, like a low back pain issue, because of the fatty tissue. So,
yeah.
I mean, you can't go one way and then go 100 degrees the other way every time something different comes up, right? So you need to kind of, we've talked about this in the past, like a bird's eye view of the research, taking a look at everything and kind of using logic. Even evidence-based medicine in research isn't based on rules. It's based on logic. So it's a matter of taking a look at everything and taking a look at the research and getting a bird's eye view of everything, and then using logic to decipher and come up with a conclusion, depending on the person that you have in front of you. Because it always goes back to, like I said before, the person that you have in front of you, right? It's an N=1 situation where you take a history and you take a look at the person that you have in front of you. That's what you're going to base your treatment on, obviously based on research, expertise, and patient values.
Well, I think we can both agree that the world could use a little more understanding of how science should be utilized at this point in time. And that brings me to what I was like, whatever someone said, like if I say something online and then someone takes that, you can find an article which will go against what I said, right? But that's also a lack of understanding of the scientific method, because you're not supposed to believe in scientists. You're supposed to believe in science. And the fact of the matter is you can find any scientist that will justify whatever it is that you're saying. But the idea is to look at science as a whole and deduce a logical conclusion from what the science tells you. And what the science doesn't tell you is the answer. And it never was supposed to tell you the answer. You're supposed to be taking this information, accumulating in your brain, and then making an argument based on the accumulated evidence and how it's interpreted. No one is going to give you, no one's going to gift you the answer you're looking for, especially in our profession. Because I mean, man, our profession, there's research for, going back however many years with regards to soft tissue management, but really our profession research hasn't exploded in the ways that we're discussing. It's only been the last 40 years, maybe 50 years. I mean, the idea of mechanotransduction, the idea of cell-to-cell signaling, the understanding as to what force does in cells. And I think that it's very easy to go to PubMed and type in, soft tissue for this injury, enter, and not see an answer and not see an article and go, oh, there's no evidence. But that's, again, complete misunderstanding as to how evidence is used, as well as a misunderstanding as to how easy or difficult evidence is to accumulate in a profession like ours, where you said the patient actually matters too. So a lot of the times in the paucity of randomized controlled trials for the exact thing you're looking for, you have to generate an argument based on basic science, based on first principles. And if you base your argument based on first principles, it's actually, in my opinion, very difficult to argue against the idea that soft tissue therapy would be a beneficial addition to
Right.
the process of managing a client. And I said addition because under no never in our history did we ever say that rubbing someone passively is ever enough. Nor did we ever say that rubbing someone in a single session will lead to lasting change. If anything, we've said the exact opposite. I've said year in and year out, give me research that demonstrates that you can put one input into tissue and that leads to a lasting result. And you can't find that evidence because it doesn't exist. So
Right.
the first thing to blow out of the water is if anybody is confused into thinking that we think that when someone comes in and they're in pain, that we can somehow rub away the knots or break up the fascia or remove the adhesions, that is not the pile of shit that we were laying on. And we never were.
Never said. That's
Never.
right. Never said that. I mean, breaking up adhesions is something that we've never talked about, right?
Yeah.
We've always talked about the fact that, we don't fix anything. We're just part of the process of changing things.
Exactly.
And trying to use tools in a very scientific manner, including manual therapy, including soft tissue work, in order to help along in that process.
And we've been saying, and then people nowadays, there's this other crazy line of thinking where, yeah, well, that's right. All you have to do is work, get strong, as if getting strong fixes everything. And that's yes, it's true. I would say the strongest signal in the ongoing health and maintenance of someone's tissues is going to be force inputs by way of exercise. But the idea that the exercise can just randomly be exercise can only be concluded if you don't understand how cells understand their environment. It's very specific, as we're going to get into. It's not like these things are just haphazardly, laying down tissue in whatever manner. It's a very specific process, whatever you want to say, that I think it deserves looking into. I mean, it deserves this amount of attention to be given to it. So let's start with that. So first off, let's categorize things. So the idea of an adhesion, we're not going to talk about this. There's no such thing as an adhesion that's perceptible under human touch. I mean, conceivably, an adhesion would be a piece of collagen which is laid down in, some haphazard manner. And the idea that someone can feel this piece of collagen and then understand the directionality of it or the texture of it based on touch, batshit crazy. That doesn't make any sense. So let's talk about what actually happens, which is fibrosis. So, I mean, crazy question, and I know this might sound crazy to someone like you who has studied this for so many years, but this is legitimately something that you see online. Does fibrosis exist? Without laughing your way through this, can you somehow describe why that is such a inherently crazy question to ask?
Okay, so I mean, fibrosis, does exist. It is one of those histological processes that happen in our body following an injury. So any type of injury, from simple strains and contusions, to more severe trauma, like tendon tear or a ligament tear. So if we were to define fibrosis is the abnormal, sometimes chronic. So it becomes, chronic in pathological conditions, overproliferation of the extracellular matrix, right? So the extracellular matrix is in all of its components. So, we're talking about cellular components as well as protein components. So in the cellular components, we're looking at stuff like one of the important cells, I guess, in connective tissue being fibroblasts. And when we're talking about proteins, we're talking about all the other stuff that's found within the ECM. So collagen fibers, elastin, reticular fibers, those types of things, glycans, and the rest of that stuff. So in the long run, so if you're taking a look at long-standing fibrosis, which, like I said before, in severe cases, it becomes pathological. But in general, fibrosis can interfere with, tissue regeneration. There could be a decrease in function, like I mentioned before. And it's going to alter for sure the environment of the tissue, which again, it's going to increase susceptibility to a re-injury.
Mm-hmm. Now, when we say fibrosis, like we know the answer, but I'm going to ask it. What's it made of, John? Like, what do we mean by fibrosis? So you said the abnormal proliferation of extracellular matrix components. Is this what you said?
Correct.
Okay.
Correct. So, if we want to, take a look at, maybe this is the best way to do it is if I kind of go over again what happens during fibrosis. So it all begins, with fibrinogen, which is a protein, and then fibrinogen, which is found in plasma, gets converted into fibrin, and then that's when a blood clot gets placed in that area. So we have a formation of a blood clot in the area. So this happens in the early stages of inflammation. So what you're going to do is, what you're going to see is that you're going to see that in the inflammatory phase, you're going to get matrix being formed in that area. Okay, so when we talk about a matrix being formed in that area, there's an invasion of various cells, and one of those being, of course, fibroblasts. And fibroblasts are going to enter that area. They're going to dissolve the clot, and they're going to start replacing it with collagen. Mm-hmm. So collagen is being laid down at that point in the early stages in what we call a reticular formation. So it gets formed down as a reticular collagen pattern. And the reason why it's called reticular is because there's specific collagen fibers that are being laid down. Mm-hmm. And those are namely type 3 collagen fibers. Mm-hmm. Normally in connective tissue, we see a lot of type 1 collagen fibers. Mm-hmm. and type 3 as well, but mainly type 1. And the ratio of type 1 to type 3 favors type 1. Mm-hmm. Following an injury, in the initial stages, you're going to get deposition of type 3 collagen fibers. Mm-hmm. And they're going to form almost like a mesh. Okay. Mm-hmm. The problem with collagen fibers and type 3 collagen fibers is that they're very thin and they're very weak. Mm-hmm. And so they're not as dense as regular collagen or type 1 collagen. So what does that mean? That means that you're going to get between those fibers, between those collagen 3 fibers, you're going to get a lot of cellular content. So you're going to get a lot of fibroblasts in that area. Mm-hmm. So what that means is that tissue is going to be a weak tissue, because the protein content of that ECM is not going to be very dense. Mm-hmm. So when there's a bigger distance between these collagen 3 fibers, you're also not going to get as good of a covalent bonding between those fibers. Mm-hmm. So that immediately makes that tissue not very normal, right? Mm-hmm. So it doesn't look normal histologically, but it's also very weak.
Mm-hmm. I gotta jump in here because some whatever person on the internet was speaking. I often say that fibrosis is normal tissue laid down haphazardly, and then people are like, "Oh, no, they crazy people." Clearly, what I mean by that statement is that what you get is a collagenous based mixture, which is going to bridge the gap. So what I mean by when I say that it's just haphazardly laid down tissue, what I mean is it's still collagen. So the extracellular matrix, it's producing collagen. I think there's 52 different types of collagen right now that the literature is. Am I correct with that?
There's close to 30, and then they're still working on other types. I mean, there's constantly new types of collagen being discovered, right? So there's tons of, and kind of jumping on what you're saying is the fact that that's what exactly the tissue. It doesn't look like the native ECM normal tissue.
Mm-hmm. What is it? Okay, go ahead with that. So what does it look like?
So again, the collagen 3 fibers are going to be thinner, and so there's going to be a lot more space between those fibers. So it's going to be less dense, making it weak, and it's not going to have the same pattern as a normal ECM would, with more of a collagen 1 fiber in there, right?
Which is why I say the word, it's laid down haphazardly, and then people, once again, they jump on and they go, oh, he doesn't know about he doesn't know about collagen type 3. He's never read about that, which is a crazy statement. Clear. And now, so this goes back to Jarvinen's Jarvinen in muscle healing. We've heard about this before. So you have this injury, and then you have this piecemeal patchwork where fibroblasts are in the area. They're going to deposit this. They're going to start to produce collagen. The extracellular matrix is going to be altered. Now, therein lies the problem, is that if we go back to the evolutionary understanding, you would think that these cells are going to invade, and then they're going to put things back to normal. They're going to start to deposit type 1 collagen, but normal doesn't happen for a long time past that point.
Correct. I mean, this happens about 2 to 3 weeks after collagen 3 gets laid down. So, what I just mentioned now happens initially. 2 to 3 weeks later is when you start seeing more of a collagen 1 again being deposited into that ECM.
So now there's like a race to healing.
Correct.
Okay.
Correct. So collagen 1 gets laid down at this point. And as collagen 1 gets laid down, and this ratio, this conversion of collagen 3 to collagen 1 happens, this kind of depends on a few things. It depends on enzymes and how quickly all this gets converted. And it also depends on mechanical stress and strain onto the tissue. So stress and strain then what are these synonymous with? They're synonymous with lengthening. And obviously when talking about lengthening, we're talking about directionality, right? So that tissue needs directionality. It needs stress and strain in order to get laid down in a specific way. It's going to help that tissue heal better.
So in other words, like we say, the only language that is being spoken here is the language of force. That's why we say force is the language of cells, movement is what you say. So there's no positive of evidence demonstrating that in absence of force inputs into a damaged tissue, what is the result long-term of the healing process? So let's say you have this injury and the person is immobilized for a period of time. What does that look like histologically in a few months down the line?
So again, when we talk about immobility and immobilization, you're going to see a lot of muscle tissue being replaced by either fatty tissue, and you're going to get a lot more connective tissue being laid down. So you're going to get a lot more fibrotic tissue kind of filling up the space, filling up the gaps. So you're going to get a lot of more thicker connective tissue. You're going to get less muscular tissue in that area.
Okay.
And the way that tissue is going to be laid down is going to be not very directional.
So haphazardly.
So take a look. I'll give you an example. Take a look at a tear in a tendon.
Okay.
And if you take a look at tendons have a very dense, tightly packed collagen arrangement. And so when there's a tear, you're going to see very disorganized tissue in that area. So that tissue, if you take a look at it under specific electron microscopes, you're going to see that tissue is going to be very disorganized while in the immobile stage. So if the tendon isn't moving, you're going to see a lot of tissue being laid down in a disorganized manner. It's not going to be laid down densely packed along the lines of that tendon.
I'm glad you brought up tendon, because let's take tendon and ligament specifically, because when I say the analogy, let's call it, that an injury leads to a haphazard, it leads to healing, and the healing, it leads to scarring, and the scarring is normal tissue laid down haphazardly. So what I mean, of course, is that it's still collagenous, it's still collagen-based tissue that's but it's laid down haphazardly, and no tissue is this more apparent than in ligament and tendon, where the directionality of the tissue is visibly easy to see. I mean, a ligament literally has lines. It's not crazy to draw lines like this, which is another thing that I do during seminars, just to help people understand, to draw lines like this and say, well, in an injured tissue left to its own accord, which is immobile, to have, you know, a haphazard pattern. And that is legitimately, with tendons and ligaments, that is legitimately the answer.
That's what we see.
It's exactly what's seen, and it's been seen over and over. Not to mention the fact that you take ligaments and you let them heal by themselves, and the ligaments always end up being thinner, so they're not going to be as robust. So in ligaments and tendons, it's actually very obvious, and the analogy that I often use is very specific. And usually when I use the analogies, I'm discussing, you know, ligament ruptures or tendon tears.
Right.
Yeah.
And since you mentioned this, I mean, you mentioned directionality. We have to realize that there's directionality in all subdivisions of connective tissue. I mean, it might be a little bit more evident in ligaments and in tendons, because that's where, you know, collagen fibers are more densely packed. But if we take a look at, you know, the intramuscular connective tissue, there's a specific pattern in the way the ECM and the collagen fibers are distributed within the intramuscular connective tissue, right?
Go ahead. I'm gonna.
So, I mean, in the epimysium, which is the tissue or the connective tissue that covers the muscle as a whole, it's a little bit more random. But if you take a look at the perimysium and the endomysium, you're going to see a little bit more regularity there. Sorry, especially the perimysium, because the perimysium is actually the intramuscular connective tissue that pretty much is continuous with then the tendon.
The tendon tissue is pretty much perimysium.
Correct.
Yeah, continued down. Which is why we often say that a muscle doesn't have two tendons; it has thousands and thousands of tendons, because technically each fibril or each fascicle ends at a tendon. And the fact of the matter is that not all muscle cells reach from actual tendon to actual tendon.
That is correct.
The fascicles are of a variety of different lengths.
Correct.
Of course, if the longer you get these fascicles, the better you are, because that means you can produce more force, you can defend yourself against more injury. And that's also apparent that fascicle length is a contributing factor to chance of injury.
Right.
So that would mean that at every point where a fascicle ends, that terminal point technically is a tendon. So there's a variety of different tendons.
Right. Because it's still connective tissue, right?
And that also speaks to the idea that perimysium is, I would say, you can correct me if I'm wrong, the most directionality organized of the intramuscular connective tissues.
It is. And if you take a look at the perimysium, you're going to see that collagen fibers are laid down in that bundle, or around that bundle, I should say, in 55-degree angles to the axis. I mean, and this is at resting length, right? So we see this at resting length. And the reason why it's, you know, obviously is in that position is because it allows it to lengthen. So as it lengthens, we're going to see that angle decrease. So those 55, if this is my axis, and so collagen bundles are being, they're laid down in perimysium at 55 degrees, as that tissue now is lengthened, that angle is going to decrease, which allows it for more length.
I'm gonna bring something up here, because I think this is where people get the most confused. Can I zoom in here? I can. So we have to start making some, you know, we can't. The problem with now is that the word fascia has been so confused in our you know, circles, that it's now meant to be just the filler of every space in the body, without understanding that there are differences in fascias depending on the location of the fascia and the production of that fascia. I always say that, you know, when you're dealing with the human system, there's very few things that are pre-proteined for. And what I mean by that is that, you know, where the connective tissue goes, where muscles are, where ligaments and tendons are, these are secondary effects. Where the the embryo is protein for is to determine where spaces need to be created in order to make articulations. And then past that point, the act of moving and the act of using the tissue teaches the tissue what it's going to become. It's not like there's a time where the body goes, oh, we need more ligament there, so start producing ligament. It doesn't do it that way. The cells don't have brains. Okay, the nucleus is not the brain of a cell. It's just the area that houses the DNA. So what is protein for is where these spaces go. And then as the body is used, that is going to dictate what happens to the tissue. So it's not like the body goes, okay, put fascia there, and fascia is just a one word that covers everything. And here's what I mean. Oftentimes nowadays, people use, I think they take a clipping of this picture that I'm showing you. Can you see this image here? Mm-hmm. They'll take let's say a square picture of this image, and it's hard to see here because it's blurred. But in this image, it appears that the fascia has no directionality, right? Because the tissue is just going everywhere. So then I've literally hit people online come at me and say, well, you're talking about directionality of tissue, but look, fascia has no directionality. It hurts my brain, John. It really hurts my brain in that when people are reading a study, they usually have this thing on the bottom of each picture, which tries to describe the power of the microscope looking at the image, and that matters. So in other words, yeah, if I zoom right in on this at the extent of at the exclusion of everything else, it's going to look like there's no directionality of tissue. But what you're looking at here is endomysium. And yes, it's true. Endomysium has less directionality than the covering paramysium, than you know what I mean? And even epimysium has less directionality than the paramysium. But that doesn't mean it doesn't have directionality. And I'm going to show this because I try to, if I give you tissue, if I give you tissue and I tell you that the tissue has no directionality, I zoom right in and I go, see, that's what fascia looks like. But that's a two-dimensional picture. When I take it out of the two-dimension and I look at what it looks like in 3 dimensions, well, guess what? Now this tissue has directionality because it's forming a tube whereby muscle cells will sit in that tube in a very specific direction. So again, when you're reading an article, you can't just look at pictures and make vast conclusions about these pictures without understanding what depth you're looking and the specifics of what that tissue is creating.
And that's how anatomy is really in reality, is three-dimensional. If you go further down in those images, there should be an image of the paramysium and the paramysium bundles that show the
you know where it is specifically?
Keep going.
We're going to come back and forth between this stuff. There we go. That one?
Yeah, well, this shows, these images here shows what happens with immobility, right? Mm-hmm. So immobilization. So we see normal tissue. So you see there's some type, and again, this is at a macroscopic level. Exactly. But you still see the disorganization, right? That happens 3 weeks post immobilization.
Mm-hmm. But I mean, if you do zoom in on this, you see that, of course, cross-links exist, and we're going to get to cross-linking in a second. We'll talk about cross-link. So no one's saying that, every single collagen fiber is laid out in a certain direction. But what we are saying is that even in the randomness of appearance, right? If you could zoom even more in on this tissue, wherever the lines of force are predominating over time, those fibers are going to have more robustness than the fibers that are not going in the direction of the load that occurs over time. So number one, this idea that fascia is just this thing that goes everywhere and there's no directionality and there's no need to worry about directionality. I mean, that's a basic misunderstanding of microscopes more than anything else.
Right.
Right.
If you go up a little bit, some of the images, if you go further up here. So if you take a look here, that image on the right is paramysium, right? So you can see there's longitudinal cables, as they're called, that go along the axis of the bundle.
And then
there's some smaller connective tissue that run horizontally between bundles to kind of connect those bundles and distribute forces in that direction as well.
Exactly. But I mean, this, as you can see, is not the same as this. And that's because that's why there's different words to describe these things. That's why there's something called endomysium and something called paramysium and something called epimysium. And I realize that what it is blurred because all tissue blends together, but it's not just all called fascia. And that is not the case. So speaking of which, the endomysium is more haphazard, of course, than paramysium. And then epimysium is also more haphazard than paramysium. Now, that makes sense, of course, because when you're talking about epimysium, the covering of a muscle, this has to distribute loads not only along the lines of force, but it also has to distribute loads between other bundles of muscle. So therefore, that interface is going to have less directionality because it's dealing with more directionality of force. Is this correct?
This is absolutely correct. I mean, we see this in a couple of other places. We see this in superficial tissue, so subdermal tissue, right? So fascia superficialis.
Again, we should stop here. There is something called fascia superficialis, and then there's something called fascia profunda, and they're not the same thing. So what's fascia? Go ahead and what are the differences between these two? What's fascia superficialis?
If you take a look at this histologically, so if we kind of want to relate this back to the ECM, the way the ECM and the collagen proteins, the way they're distributed in the fascia superficialis or the subdermal tissue is in various directions. So in that situation is where we want and where we see like a meshwork of collagen, because there's directions, there's forces going in various directions. So that tissue has to be able to account for that. Same way we see various fiber directions in capsules. So again, capsules, because there's more degrees of freedom, there's more movement happening there in various directions. We're going to see various directionalities happening within the capsule of a joint.
And I would argue, going back to the evolutionary process of how this tissue is developed, if you create a space by way of cavitation in the glob of cells that used to be us, that space has to be understood. And the way it's understood is by the first level of tissue, which later becomes the capsule. And that capsule needs to understand space in 3 dimensions. And that's why it has less directionality, because what you're doing is you're trying to take a space that gives you degrees of freedom, and then you're trying to confine that space. So it's going to be privy to a variety of different loading directions over time. Ergo, it's going to develop with a variety of different loading directions in time, right? Whereas
what happens if you don't load it in all directions?
Exactly. And then you get this.
You get limitations in that workspace, right? So that joint will have a limited workspace because that tissue is not going to be able to lengthen or account for, a change in that direction.
Which is why at a microscopic level, even when you're looking at an electron micrograph of tissue that looks haphazard to your eye, it doesn't mean it's haphazard to the system. The system, how else would it have been laid down? If it wasn't being laid down along the lines of some loading inputs, then there's literally no other way for tissue to know how to exist. Because
again, this is something that we know from histological studies. If you take a look at fibroblasts, and they've done this in the lab, obviously, I mean, it's definitely hard to do it, in vivo and in tissue, but because I mean, there's imaging involved, and it's very expensive, and there's lots of variables, etc. But if you take a fibroblast and you activate it, which means that you're going to, what it does, it kind of shrinks and it kind of flattens out. And when a fibroblast gets activated, it's going to lay down collagen fibers along those stress lines. So it's going to get, so that's what happens. That's those stress lines are direction. It's directional.
Non-debatable that happens. I mean, it's not one study, 2 studies. This is a whole genre of evidence that demonstrates that fact.
And then it's having tools, whether, it's, soft tissue, and we can get into this, or exercise, which is more global loading, being able to lay down tissue to help that tissue kind of get back to a almost like a normal type of tissue structure.
Which is why the understanding of the anatomy past this, you just got to make it strong, and strength is all you need, and as long as it's strong. Well, no, if you know this fact, then the specificity of the inputs that you're able to impart on your clients will lead to the development of better quality tissue that has more directionality. So understanding that, things do have direction, and of course they have direction. You never see a bicep grow in this direction. I don't know if anybody's noticed that, but biceps always grow in this direction. And that's because it helps bring things to the face, not because there's a genetic code in the DNA that says biceps must look this way, but it's because the information flow goes along a direction, and that information flow will lead to the development of tissue to allow for that information to flow properly. Now, where is there confusion? Yes, there is confusion in that when a force is being generated, and now we know better. Before, when we talked about the sliding filament theory, for example, and this idea, there's just actin and myosin in a contraction, and it crosses over, and the cross-link, it's stuff that we learned, back first day, first grade. You know what I mean? Like, we now know that model is largely incorrect as well, because that model really describes what's happening at one sarcomere, by itself. But if you take the larger understanding of muscle, we now know that as actin and myosin crosses, it also separates, because when a muscle contracts, it's going to radially expand, which means a lot of the directional forces will permeate laterally. And there's a large amount of lateral permeation of forces during contraction. But that's also still to help the information in the direction of the flow. It doesn't mean that, doing bicep curls will lead to, collagen being laid down. It's not like I'm going to look at a bicep and all of a sudden see fibers being laid down sideways. I mean, that doesn't happen either. Am I correct in saying that?
Of course. Yeah.
Yeah.
Totally.
Okay. So we have different layers of connective tissue. We have, the fascia superficialis, which is really the connecting tissue between the skin and the underlying tissue, right? Of course, the skin can move in a variety of different directions, so there's going to be less directionality. Then you have your epimysium, and then you have your paramysium. Did you want to say more about the paramysium itself, or?
I think I think we touched on the fact that there is direction to it. The ECM, the connective tissue, the collagen fibers do have a direction. There's a directionality within that tissue. It's not just just a meshwork of collagen. You kind of said it correctly by taking a look at things in a two-dimensional or on paper or under the microscope. If you take a look at things at a deeper level, you'll see that there is directionality there.
Yep, and that matters. The idea of understanding what level your microscope is at, it matters when you make conclusions as crazy as fascia goes in every direction. And I think that as a soft tissue therapist, this is a very potent understanding. A lot of people will put their hands on a body and they'll just start moving everywhere, and they go, well, fascia goes everywhere, but no, fascia doesn't go everywhere. It is everywhere, but fascia has a function, and the function is determined by force,
right?
And there's no way around that. So yes, there's more directionality in some connective tissues than others, but the argument that there's no directionality is a failed argument. It doesn't really make a hell of a lot of sense. Now, another thing that has been brought up in a lot of years is this idea. I can't remember the article. Maybe you have it off the top of your head, but there is an article looking at the amount of force that a soft tissue practitioner can ostensibly put into tissue. And then that amount of force was contrasted against the amount of force it would take to rupture the tissue.
Right.
And I can't remember the exact article.
Get the author. Yeah, they did this on the IT band.
And then all of a sudden, again, wild conclusions. All of a sudden, the conclusion was that because you are unable to put the forces necessary to rip tissue, then the conclusion was that there's no point in doing soft tissue work.
Right.
Now, do you try to rip tissue when you're doing soft tissue work? Is that the goal?
That's not the point. And
Okay.
You know, nobody talks about, you know, at least we haven't ever mentioned the fact that we said this before, that we're breaking up scar tissue or we're ripping connective tissue apart.
Mhm.
You know, what you're trying to do is get that tissue to start adapting and providing various loads and forces onto that tissue to initiate a change. I mean,
Okay.
that's pretty much what's happening, right, with what we're doing.
And then that change, of course, has to have, you know, the signal has to be given in time, but over time. So in time, what we're saying is if we can give some directional signal into that tissue that is later followed up with exercise, which reinforces that directionality, that we can improve on the end result of the connective tissue that is laid down.
Correct. The whole idea is to create directional load onto that tissue and to initiate a process, to activate, you know, the fibroblasts in that tissue to start creating that process. And, you know, we take a look at, you know, work, for example, by Langevin, and, you know, she worked more with acupuncture and needles and twisting needles. And you saw that when she provided direction with that needle, she was able to activate fibroblasts. So it doesn't take much force.
I was just going to ask that. So what is yeah, I mean, you don't have to quantify that, but I guess you just answered my question. The amounts of forces that need be imparted in order to create cellular signaling is not a high amount of force.
No.
Okay.
From what we know, and from, you know, the concepts like Mechanotransduction, we know that, you know, forces are what create activity in cells. And so what the research shows us, or at least some of the research that shows us, is that we don't need high amounts of force to activate that tissue or to initiate that process.
Okay. Now, let's talk a bit about the directionality that can be imparted by soft tissue work. I would argue that the idea that you can move over the skin and that that's somehow going to give a directional information to the underlying tissue, I would not agree that that would be possible. So the idea, if I'm a fibroblast, right, and I have, you know, there's skin over me here and there's tissue, right, filling this gap. If you just kind of roll something along the surface of the tissue, to the fibroblast, the resultant force that it feels is this. So it's just a compressive force that really doesn't have much in terms of directionality. But this, of course, is why effective soft tissue therapy will include movements. You know, sometimes they do it actively. I would disagree that that's a good way to do it, but at least passive movement with directionality of the thumb, imparting a force in a particular direction. Now, there's some, you know, people often point to this one study by Ross and Bereznik about there being a frictionless interface between the skin and the underlying tissue. And somehow that study, which by the way was done on 2 people, as far as I remember, and it was the authors themselves, whereby they took a mold of hands in a particular position and put it on the skin, and then had this machine kind of roll over the skin, and they realized that there was no increase in forces, and therefore the conclusion was that there's a frictional interface, which I often found weird, because if you grab the skin of your elbow and you tug on it, it's not like I can pull the skin of the elbow onto my head. Like I can't grab my outer connective tissue body and just turn it around, which would be a frictionless interface. Clearly, there's friction at the end of any type of force you put in.
Right.
So I suppose what we're saying is that under low loading environments, which is what's necessary to create fibroblastic change, the application of a compressive and then a directional force reinforced by the moving of the tissue underneath that stimulus,
Creating length is what you're saying, right?
creating length would be the stimulus that would lead to at least an understanding as to where the directionality of information, where the directionality of flow, where the directionality of tissue would have to be laid down. Am I incorrect in saying that?
Correct. I mean, if you, and this again is where I want, talking about lengthening and stretching, and you mentioned this initially during this conversation, but, I said there was a study, and there are a couple of studies that are, that were done that show that stretching decreased soluble TGF beta, which is an inflammatory agent, which is found during fibrotic tissue being laid down. So by lengthening that tissue, creating a brief stretch with what we're doing, in addition to loading that tissue, you're trying to activate the cellular components of that tissue in order to create some of those changes that we were talking about before.
Now, I don't want to overplay the literature hand in that I don't want to say that there's research that's demonstrated, thumb goes in, this goes this way, and then you have the resultant tissue. What we're trying to do here is we're taking first principle research, and then we're combining it with clinical clinical research, and then we're coming to that conclusion based on that. As I said earlier, in absence of direct RCTs, the clinician is left with the understanding of first principles and the logical application of first principles in order to try to create the changes that we want to make. So just because that research doesn't exist today, it doesn't mean it's not going to exist tomorrow. And we have to make predictive guesses based on the knowledge we have now. So what do we have now just based on this conversation? Number one, tissue, in fact, has directionality, which is, it's not one of those things that can be argued, because even at a global level, you can see the directionality of tissue. When you go into a microscope, you see that there's less directionality in some areas. There's cross-linking, of course, but that doesn't negate the idea that there is directionality in tissue. We also know that in development, that directionality of tissue would have been initiated by force inputs, because that is what leads to, if you take an embryo right when, let's say, the joint space cavitates and is created, if we somehow clamp down on that joint space and then let the embryo continue to develop, what we're not going to get is a normal joint. We're going to get haphazard, tissue layers, because when a fibroblast doesn't know what to do, it's like when you injure yourself, fibroblasts invade in the area. If you're immobile, the fibroblast it's listening for signal to know what to do. If it doesn't get that signal of force, that's what I mean. It starts to lay down tissue in a haphazard manner, which means the wrong type of collagen over time in the wrong direction. So tissue has directionality. Force is what births that directionality. The amount of force necessary to signal, at least to initiate the signaling of that directionality, is not very high, as would be demonstrated by these people saying that you can't rip fascia, as if that's the conclusion. And then the idea that if you put force in and then move tissue along its directionality, these are the kinds of conclusions we're making. Now, if you add those conclusions to the idea that it's not really debatable whether or not therapeutic touch is effective. Right.
We're not going to get into that. I mean, we could do this some other time, but we can get into some of the other stuff when it comes to.
So then the question becomes, well, for the people who have doubts about this, if most people doubting this still say, well, yeah, I do soft tissue on my clients, Well, you can either make the decision, the conscious decision, to haphazardly apply soft tissue, right? Just because you want to conclude that the evidence is out that there's no such thing as directionality and it doesn't matter what you do, which, by the way, there's no evidence for that. That we're talking about, we're on this level playing field. So it's either you take the evidence about what we just went over and you say, well, we should probably be directionally loading this tissue, right? I mean,
don't forget
go ahead.
Yeah, and don't forget that we add global loading, right? So on top of the soft tissue, we're adding pales and rails. So we're moving that patient towards more active strategies. That's the whole point. That's part of the whole process.
Yes. If people are making the argument that people rely on soft tissue too much, I think that we will both agree that that's 100% true. You don't want patients to be dependent on your soft tissue inputs, especially for things like pain management. And this is also not, that is also not good science. The idea that you tell your clients that I'm rubbing the pain away, or I somehow am breaking adhesions or scar tissue. I mean, that's intellectually dishonest.
Right.
Just as intellectually dishonest as saying, for example, that connective tissue has no directionality. These are dishonest claims, or claiming that there's evidence against the utilization of soft tissue. Because how do you define it? You take a lot of this evidence, and a lot of people will agree that exercise loads tissue directionally, and that if you're rehabbing an injury, you should take into account what is the anatomy that's injured, and then base the exercises off that anatomy, in so much as saying it's not just randomly get strong. So they can understand it at that level. But as soon as you bring it back down a level and you start saying, okay, well, if we're going to put forces in with our hands, maybe we should put forces in the exact way that the research does tell us the cells understand the forces.
Right.
Then why wouldn't you?
Right. And I guess this is a good point to kind of transition into outcome measures. Because people, outcome measures are things that we kind of need to define, because it's these things that we, ultimately have to change. And so the presence of outcome measures in manual therapy is important, because it's going to guide both our intent and what our plan is going to be with our soft tissue management, right? Or management of our patient. The problem with all these outcome measures is that many colleagues use pain as an outcome measure when it comes to manual therapy.
This is a big point. Yep.
Right? But we know that pain does not equal, or it's not a sign of structural damage necessarily. So just because you're poking on somebody and specific points on the body create tenderness or pain, that doesn't mean that those are necessarily a problem there. So many people are right, and so people are still kind of basing their argument on the fact that manual therapy on its own will not have a huge effect on pain levels or the general health of an individual. But then, if you take a look at things and you take a look at research, neither will exercise prescription, neither will surgery. So all these methods show a similar effectiveness when it comes to kind of pain and general well-being. But we have to kind of go back, and if we're dealing and we're talking about manual therapy, then and we're talking about affecting tissue, as we've been saying throughout this podcast, then you want to use outcome measures that are tissue-based outcome measures. Right? So that's where you want to see where you're going to have an effect. And using tissue-based outcome measures is what you need to use instead of having more mechanical outcomes instead of pain outcomes when you're dealing with some of these things.
Yeah, it's almost as if the people would think that we somehow disagree with the pain science research, as if we're allowed to disagree with research. Like, we're not disagreeing. The pain science research is what the pain science research is, and like you said, the correlation is not high. However, I can jump on that side of the argument too, and argue back the other way and say that, like you mentioned, I mean, there's a lot of soft tissue work that is done for no apparent reason, just because people are searching for the boo-boos that hurt. Like
Right.
I often say, if you're a fly on the wall in most, let's just say massage therapy rooms, and you can watch treatments and you watch 10 treatments in succession, what you'll likely see is 10 treatments where the exact same areas were focused on, because there are predetermined areas in the body whereby palpation leads to pain in normal tissue. Like, for example, like, I mean, if you push in here in a person, in these regions here, it's gonna hurt, right? And then of course, people who don't understand anatomy go, well, that's the QL. And then we say, well, no, open up a dissection manual and you realize that's not the QL. And the QL is actually, I would say, 95% covered by the erector spinae itself. So the amount of QL that you really have access to is a very small amount. It's more central, blah, blah, blah. But what you realize is that people are pushing into the kidneys. And you know what? It fucking hurts to push into kidneys. Just like if you push into the buttock right in the middle, well, that's irritation of the sciatic nerve and blah, blah. Well, no, it's just the fact that that area is more sensitive to palpation, as is the lateral portion of your elbow, as is the best one is the levator scapula trigger point.
Right.
I love when people point to the levator scapula trigger point down here, and then you go, what are you pointing at? And you go, well, this is the spine of the scapula. And then you go, where does the levator originate from? And they go, oh, it's from the superior angle of the scapula. And then I show them that the superior angle of the scapula is over here. So why are you pushing back here and telling me that's a levator? It's not a levator. It's just a point in the body which is more sensitive to palpation. Like I can punch you in the arm, it's going to hurt, or I can punch you in the jaw, it's going to hurt more. It doesn't mean your jaw was messed up. It just means that that's how the body is, right? So I don't want to get people confused into thinking that. And that's another thing, is that a lot of the times, someone comes in, oh, it hurts here. And then the person does the soft tissue therapy, and then they go, how does it feel? Person goes, oh, it doesn't hurt anymore. And then the soft tissue therapist pats themselves on the back as if they did something, not understanding the concept of touch-induced analgesia, right? Like if you hurt yourself here, you can rub it, you can pat it, you can do whatever you want. And guess what? The pain level will go down. That's not an outcome measure.
Correct.
Right?
It's not tissue-based outcome measure. So what are you really doing that you're not doing anything, right? Same thing with.
By the way, now that we're on this topic of, and you, I won't interrupt you next, but range of motion is the same. Like, don't show me someone's range of motion and then do soft tissue therapy and then show me an improved range of motion that day and tell me that you accomplished anything, because you haven't. Right. Because when you rub something, pain goes down. Pain goes down, range of motion tends to go up. But 2 days later, when pain goes up, range of motion goes back down. So,
right.
Go ahead if you had something.
No, I mean
that goes to show that like you would say, the outcome measure that people are using is incorrect. And I mean, nothing messes up someone's understanding of anything than using wrong outcome measures. I mean, if you're using the wrong, I mean, there's literature dedicated to this concept of trying to reduce pain using, management with
I think we know this. We've all come to the conclusion that when soft tissue and pain is multifaceted, right? So I mean, there's lots of reason why somebody is going to be in pain. So I think we got to move past that. I think research is still trying to prove something that I think we all understand, that pain is multifaceted, and soft tissue, we're going to try to affect things in a different way. So more on the tissue-based outcome side than on the pain side.
And then on the tissue-based outcome side, it's just a matter of coming to the conclusion that there is such thing as optimal, and there's such thing as suboptimal. And we've talked about this now for a few hours now, is that the research is not, it's not confused on this point. Like, if you look at a tissue, if a surgeon looks at a tissue, if a therapist looks at a tissue, if you put an electron microscope on a tissue, you can point to that image and say, there's something wrong with that, whereas this one is normal. Now, if you can say that, just saying that means that we know that there's something over here that's not right. And what we mean by not right is it's not going to produce or accept forces in a normal way versus normal tissue, right? So if we agree that fibrosis exists, I mean, you've done this as well too. I've been in surgical scenarios where I'm observing surgeries, and you go into a severely arthritic joint. Just with your eyeballs, you can see that there's tissue that's abnormal, right? It's not like it's not like you need some special magic powers or glasses. You can see physically that that person's tissue is normal and this person's tissue is not. So if there's an abnormality of tissue, and we agree that tissue is in time based on force profiles, then we have to agree that if the force profiles, and we know that force is what directs how tissues lays down, then by normalizing force profiles, we would make that tissue closer to what optimal is. Right. Or else we would, on the flip side of that, we would have to say that there is no optimal, and it doesn't matter how much cross-linking there is, and it doesn't matter about the directionality of the paramecium, and it doesn't matter because when I touch it, it still hurts. I mean, but it's a piss poor use of outcome measures.
It is, exactly.
I mean, we can keep go on this for days. Is there anything else that we had to cover in this particular topic that you want to, and we can go backwards, we can go forwards. If there's anything else you want to talk about, do you want to talk more about this cross-linking? Is that something that you think confuses people?
Cross-linking happens at two levels. I mean, it happens as collagen gets formed from tropocollagen into that triple helix. You're going to get covalent bonding and cross links, and then you're going to get cross links at a more macroscopic level, I guess, between collagen fibers within the ECM. Remember I said before that covalent linkages or covalent bonding is a little bit weaker in the initial stages of repair when you have collagen 3, because there's more space there. As that tissue is going to mature, you're going to get more covalent linkages between the collagen 1 fibers, which are denser, are going to come a little bit closer to each other, making that tissue a little bit more dense and a little bit more stable. The problem with covalent bonding is that you don't want too much of that, because when you get too much covalent bonding, which happens when you have too much tissue there with no direction, is what you're going to get a pathological process of fibrosis happening. So now research is being done to show that if you have increased covalent bonding, you're going to get more thicker tissue that's even less functional. So we see this in age, in people that are older. We see in their tissue that we have a lot more covalent bonds, covalent links that make that tissue less pliable, less elastic.
When you're assessing for fibrosis, we'll both agree that it's not something that you can feel in terms of a textural change. It's not like we're feeling for something that feels like fibrosis, right?
Right.
I think people, I'm going to give this to you, but I do want to point this out. I think people don't really understand what our receptors are there for. And the vast majority of receptors are there to, they feel force, right? It's like wetness. When somebody says something feels wet, nothing feels wet. Your body cannot feel wetness. It just feels temperature change. And then it feels temperature change over a gradient over your skin, which then allows you to determine that you're feeling something wet. Does that make sense? Obviously, you know this. But people don't know that. People are like, what the fuck are you talking about? But the truth is that we have no receptors for wet, right? Just like, you're feeling through skin. So we don't have receptors that are going to feel alterations in directionality of collagen. I mean, our receptors are not that strong. So what does first principles then tell us that we might be able to feel for?
Well, this was showed actually in a study by Jarvin, I think it was, where they looked at the immobilization of an injured tissue, and they showed that you have an increase in collagen content within that tissue that we mentioned earlier. And in this study, they showed that when you look at the perimysium, the angle of the collagen fibers, the way they were laid down, was a lot less. It was shorter, so it was closer to the axis, which meant that as you lengthen that tissue, you're going to get less elasticity. So those fibers are going to increase in tension as it lengthens more. So looking at the stress strain curve, what you're going to see is you're going to see as that tissue gets lengthened and you're getting a ramping up of that tension, a normal increase in that tension, you're going to get a quick ramping up of that tension in tissue that's injured and immobilized. So it's really what you're feeling for is a change in that tension. So change in tension means that there's a problem in the elasticity of the connective tissue.
So force. A better way I like to when I'm teaching to say, feel for resistance to movement and changes in resistance for tissue to achieve length. So the change in resistance is really what's going to be translated in your finger as an increased amount of force at length. Is this what you're saying?
Correct. Exactly.
Okay. So maybe now speak to the utilization of a set. My dog's staring at me like he wants to leave the room. He's starting to cry. So I'm gonna. There you go, buddy. So maybe let's speak to that idea that do you want to actively assess this? Do you want to passively assess this? And why?
Well, when you're looking at connective tissue and you're looking at the stress strain curve, the white stuff or the connective tissue, the way we want to assess that is passively. You want to lengthen that tissue passively to feel for that tension. Okay, that's neurologically innervated. But the white stuff, the connective tissue, you're going to assess passively.
Because you really are trying to feel for resistance, but the assessment at length is a prerequisite to this understanding, is what you're saying.
Correct.
So in order to achieve length, you want to decrease neurological tone, make the muscle relax to a certain extent so that you can access the length, which is where you'll feel this alteration in resistance.
Exactly.
Okay. And now length is also the stimulus that leads to the development of further tissue, correct?
Correct.
Okay. So
that's where you're going to get force production. That is going to be at length is where you're going to feel for that change in tension, and where, remember we said before, even with stretching, when you're lengthening that tissue, you're creating load onto that tissue.
There's also some research that describes stretching with contraction being of more benefit, of course, then because you're getting to this elongated state and then putting further amounts of force at length, right? Now, we can couple that literature with the plethora of literature that talks about training to length, training at length, being the stimulus that leads to, for example, sarcomerogenesis. And I think it was O'Sullivan back in 2012 was it? I can't remember, that did the randomized control trial, or not the randomized, it was a meta-analysis, I believe, looking at eccentric training as being a stimulator of sarcomerogenesis. Right. So, right. And so, yeah, so the idea that you can, the best stimulus to create new connective tissue would be force application at length.
Right. And what's eccentrics is you're really using force at length.
Force at length. And then to a lesser extent, you have, isometrics. Isometrics also done at length would also stimulate that kind of signal, mostly because when you contract isometrically, the red tissue is pretty much taken up right in the beginning of the contraction, and then the force then gets funneled into the white tissue, which again, at length. There's a difference between training to length and training at length, which I think people often confuse, where they say, well, yeah, I train full range of motion. It's like, well, no. Training full range of motion with a bicep curl puts you at the lengthened position for a fraction of a second before you come back up. So this idea that you're training with motion, it really should be understood where in internal strength model, we make this division between, are you training red or are you training white? And if you're training red, then yes, you want continuous motion sets. But if you're training white, one of the parameters here is that you want to funnel the forces into the connective tissue, which happens at length, right?
Right.
Which is a fundamental quality or necessity to send signal directionality, right?
Because in shortened position, connective tissue is in a crimped position, right? So at length is where you're going to get that propagation of force going through the white stuff, through the connective tissue. So that's why you want to train at length.
You want to train at length, at least if that's the exact if that's exactly what you're trying to go for. So I'm trying to go through and see if we've missed anything that you wanted to discuss about fibrosis. Or do you think we've covered everything that we intended to cover? I think we might have. So, I mean, let's review. So and we'll go point by point in this review. The first thing that we brought up here is that the misunderstanding of evolution leads to this misunderstanding of the healing process insofar as people feel that by this time our system should have known how to heal, as if the system was trying to get better. And that is a fundamental misunderstanding of the evolutionary process in thinking that there is an end goal in mind. And what we know from evolution and it just matters on the selective pressures that were apparent during that selective process. And with regards to tissue healing, that's not a strong selective pressure, because a lot of injured animals never made it out of that injury. So we could say that it was a softer selective pressure than a beneficial pressure of, I'm stronger than you, I'm bigger than you, I'm going to pass those genes on to my offspring so that they have the advantages mechanically that they need to survive. I'm not saying there's no pressure, but that is a generic misunderstanding. Bipedalism is not, there's benefits to bipedalism, but there's also a lot of downfalls to bipedalism, right? So whereas in one scenario it allowed us to look up at the horizon, it freed up our hands for the throwing of spears or of the utilization of tools or of weaponry. It also put a significant amount of stress on the spinal system, right? So it's not like that was, we got here and now we're moving towards another optimal thing. And that's why when you look at the healing patterns or the tissue healing of our species versus other species, you don't see a crazy difference, to be honest with you. I just redid this literature search leading up to this, and you do not see a ton of interspecies differences, at least mammalian differences between species. It's pretty much the same kind of thing, where if you study a rat tendon, it's generally going to go in the same line or the same vein. It's going to heal the same way, which is suboptimally if left to its own accord. Now, will we agree that an injured tissue, if the person gets up and moves, will that improve? 100% it'll improve.
Of course it will.
100%. But the idea that making those movements more specific to the force inputs that we want for that tissue, you can't have it both ways. If you tell me that moving around will be somewhat beneficial, and you know that the way tissue heals is by directionality of forces, well, then you have to conclude that if those movements are somehow more specific to the directionality of the tissue you want to heal, then first principles tells us that that's the type of inputs that you should be using.
I mean, healing is going to happen, right? We talked about the fact how the process of healing happens, and we go from mainly collagen 1 to collagen type 3, back to collagen type 1. So you get a somewhat of a healing happening. And you're right, if you move around, you're going to get some forces into that tissue and you're going to get even better healing. But if you want to talk about optimal healing, try to at least, try to get as close as you can, then, just moving around randomly is not going to cut it necessarily. Right. So look at athletes. I mean, look at, injuries and re-injuries. If that was the case, then we wouldn't get re-injured in the same spots. Right. So that tissue is weak because it hasn't progressively been loaded in a specific way in specific directions.
Over time. I mean, we can go to a very specific point with this, which is ACL rupture. And I mean, the ACL has directionality. There's no argument about this. If you look at an ACL, it has directionality. And what do they show in the literature now with regarding ACL? The number one injury you're going to suffer moving forward following an ACL injury and repair is an ACL injury leading to further repair. This is a problem that is all over, sports in the last few years, especially in the NFL. But they also are talking about the idea that ACLs probably require longer healing times, right? Whereby, you try to get, before we were trying to get people back in 6 months, right, back to play. And that got pushed to a year, and that got pushed to a year and a half, and that's getting pushed even further. And that's because if you take a anterior cruciate ligament, and then you take a semitendinosus tendon or a patellar tendon, and you put the tendon in place of the ligament, a tendon is not a ligament, right? Number one. So it takes time for the cells that are now being used as a ligament to change beneficially so that they will act more as a ligament, number one. Number two, what exercise cannot do is speed the process as to how that tissue will then be understood by the central nervous system. Because if you just you rip a tissue out, you put it here, and then you can somehow go into the brain and look at the brain's interpretation of that tissue. If it doesn't get afferents from that tissue, the brain doesn't even know it's there. So of course you're going to get re-injured. And they will, this exercise is better than this one. Who gives a shit about the exercise at that point? Until that tendon becomes a ligament, and until that ligament starts producing afferents, which probably takes a couple years, you're not going to do much to change injury rates or re-injury rates on an ACL. Right. Which speaks to the specificity of directional force loading and why it's so important, and why it doesn't happen overnight, and it doesn't happen in 2 to 3 visits. I love hearing people tell me that they fix plantar fasciitis in 1 visit. Right. Man, that either means that your hands do not have the same rules of the physical universe as everyone else, or you're a shitty diagnostician because that was not plantar fasciitis. Right. But they're like, I forgot the quote that you said, but when you're treating someone, you're not, something about dragons. What did you say? We're not killing dragons here. Is that what you said? With regards to soft tissue? Yeah, something like that. Like we're not magical. This isn't a magical thing where you rub the problem away. This is a force inputted over time with directionality in mind. So that was point 2 or point 1, this misunderstanding of healing. Point 2 is the fact that fibrosis exists. Right. I mean, we see it on MRI. We see it on signal from MRI. You see it ask any surgeon, do you see fibrosis? What do you mean? Of course you see fibrosis. We literally know how things heal from an external perspective when you cut yourself. Now, the idea that it happens internally is not a far jump, considering it's the same system, right? So we know that. Now, if you add that to the third point, which we talked about, directionality, right? Did you want to go into this?
Go ahead.
Okay, so there's the review, of course, but you jump in any time. There is directionality to tissue, and whether or not you see it based on your understanding or lack thereof of how electron microscopes work, you can't just take a picture of random connective tissue and see that there's cross links and there's fibers going in different direction and make the conclusion that fascia just goes everywhere and it doesn't matter, because as you have laid out very intelligently, which fascia are you talking about?
Right.
Right. And there's different levels. There's superficialis versus profunda. Within the profunda, there's the superficial level. There's the epimysium, paramysium, endomysium, and all of these things developed from an evolutionary standpoint based on force. And we talked about that as well, and that these things are created.
And all these tissues show directionality because of force. I mean, we talked about fascia superficialis having, more of a meshwork, and that's because there's forces going in various directions. We talked about joint capsules and how there's, collagen fibers going in various directions, and that's because it accounts for movement in various directions. Mm-hmm. When we talk about perimysium, then we start to kind of hone in a little bit on what happens there, because that perimysium kind of blends in with the tendon, which moves in specific directions. So, the directionality is accounted for, or it kind of represents, I should say, the forces that are being placed on that tissue.
Yes, and then we also talked about those forces having to be at length in order to, for the signal to be strong enough to allow the fibroblasts to know where the direction of tissue should go, which is why in an area, when the fibroblasts in this area, they don't live forever. When they go and they're replaced by daughter cells, these daughter cells, they don't know what to do either. So once again, that's why continued forces over time is what's necessary to not only fix abnormal connective tissue, but to maintain abnormal tissue through the aging process, which we didn't talk much about. But that idea that this directionality has to be given and then reinforced again and reinforced again, because there's tissue turnover in time, and right. All of your cells go away and all of your cells are replaced and all of your tissues replaced in time. So this signal is not something that happens in the embryological stages only. This is an ongoing signal until all of your signals are done and you're dead, right? So this requires that. So there's that. And then we went a little bit into the idea that there's research out there on soft tissue work. And if you look at the clinical research on soft tissue work, first off, it lumps soft tissue work into everything. We did soft tissue work and this is what we found. And then we talked about the problem with outcome measures. And are you doing soft tissue work for the purpose of decreasing pain measures? Because then we believe that your soft tissue work the outcome measure is skewed. It's not really, it's not, you can't rely on your palpation of pain to determine pain, nor can you rely on it to determine if the pain's getting better. Nor can you feel pain, nor does pain exist, by the way, in the nociception where you're touching, because that's nociception, this is pain. These are not the same thing. So we talked about this idea of pain science research and how I think most therapists need more understanding of pain science research, so you understand how little you have to say about pain in the long run with just soft tissue therapy. There's other ways of managing. You want to go into that a bit? There's other ways of managing pain. I mean, clinic, just the way you deal with your client, etc. Yeah,
I mean, patient interaction is going to be, it's a big thing in patient, education, being able to sit down with the patient. And people kind of tend to, a lot of colleagues, I think, tend to neglect the history intake. Which they shouldn't as much. People come in and say, what do you have? They'll lay them on the table and start doing stuff on them without even taking a history, making sure they understand where that patient's coming from. I mean, what do they like to be done? Some people don't like manual therapy. I mean, some people do like manual therapy. So you got to be able to judge and see how you're going to get that patient to get better when it comes to pain, using the various tools you have. Again, taking him and moving more towards active strategies and away from passive. But if you have to use passive strategies initially, you might be able to want to do that, but to a certain extent before you get them moving and using exercise.
And then the question with those passive strategies becomes, you can either throw your hands in the air and say, I'm just going to rub the person, right? Because as I said before, the most staunch critics of soft tissue therapy will say, well, yeah, I do some massage, right? They just kind of fluff it off as not being important. Or you can take first principle knowledge, which we've laid out here, and reinterpreting that you're not feeling for adhesions. What are you feeling for? Is there resistance? Does the resistance have a directionality? Does the tissue have a directionality? Can I somewhat impart manual inputs that might reinforce the directionality? Even in the learning process for that patient, the fact that you're providing directionality and they can feel the directionality, we've never looked at whether or not that enhances their ability to then apply specific lines of force in their rehabilitation. And this, this concept is, there's a lot of different ways to go. So it's either, like we said, you look at the research and you go, forget all soft tissue, right? Just get it off the table. You know what I mean? Like at one point, the earth was round, and there would have been the same kind of argument, until you give me a picture of the earth, the earth was flat. Until you give me a picture of it, forget all of this shit. Let's just continue to tell me that the earth is flat. And that's really, I mean, it sounds like a crazy example, but that's really what I put it down to, is that, are you sure? Like I would ask them, are you sure soft tissue is not doing anything? Because it seems to me like the evolutionary being that you're telling me is so evolutionarily advanced in terms of healing. Are you telling me that that evolutionary superior being can't feel the directionality of force when I impart it with my thumb? Like, think about how crazy that is. The argument is evolution has made it so that when you injure, the body can heal itself no matter what, because it's infinitely intelligent.
But isn't that backwards a little bit?
Yeah, it's so infinitely intelligent that it can't tell what direction your thumb is pushing.
Right.
I mean, how can that be the case, right? Is that what you were referring to?
Right, exactly.
It's a contradiction of the point.
It is.
Yeah. So anyway, John, anything else to add here?
I think we covered everything. We summarized, the key points.
I think we did. I think we got that. I think we developed at least we developed an argument for a substantial base of logical first principle knowledge that would lead us to the direction of saying, you know what, there's probably something to this. And if you add that to my clinical, the clinical evidence, then it becomes even stronger. Yeah, there's likely something to this, whereby the idea that we're throwing this out and the idea that, you injure yourself and all I'm going to do is hand you a manual telling you that, you'll be fine and hurt doesn't equal harm. Not that that's not important. Not that that's not an amazing addition to therapy. And again, we're not.
It's huge when it comes to pain management, right?
Huge. And we're
talking about something different. We're talking about, tissue-based outcomes. And how can we make that tissue more optimal for function, for movement, for activity?
Which later may give you the side effect of decreased pain. You know what I mean? Like, that's really what we're going for. I tell our students often that your main objective is to normalize that person's anatomy.
Right.
When the anatomy is normal, you have a better chance of that person using their anatomy in such a way that promotes a reduction of pain. That's not to say that we have to ignore all of the other things, and we do have to get this hurt versus harm, and all of these things are not ignored in any way. But to ignore, the stuff that we've talked about today with regards to helping this system along in the healing process, I think that it's a dramatic error in manual therapy.
Actually, now that you mention that, there's a study that I think Langevin did this again with the thoracolumbar fascia. I don't know if you remember this study where they looked at chronic low back patients, and she showed that there was an increase in fibrosis in the thoracolumbar fascia layers, right? So there's the 3 layers. There's increased fibrosis within those layers, causing decrease in relative motion between those 3 layers.
Mhm.
And recently there was a study done that showed that chronic low back patients there's an increase in activity of the sympathetic nervous system. There's a lot of neurological receptors within the thoracolumbar fascia. And so there might be a relation between the fibrotic tissue in the thoracolumbar fascia and the fact that the patient has chronic low back pain, because you're getting somehow a stimulation of those receptors from the disorganized fibrotic tissue within the fascia itself.
Yeah, it's like if we had a room full of all these people, I don't see why anyone's disagreeing on anything. It seems to me that, like I said, first principle knowledge leads you to the conclusions as we've stated. So again, but we're keeping in mind that this is the day and age of Instagram and people trying to get more likes. So I don't know if this is a real argument in people's minds, or if it's a, just one that's pushed on the social media realms to get attention or what. But I do feel like if this is actually people's beliefs, that we're throwing the baby away with the bathwater here, and we're making very strong conclusions that would, stimulate some people to disregard something that has quite a bit of, we do things with less evidence. We do other things with less evidence than what we have for soft tissue work. Way less evidence than we have for soft tissue.
People to think, a little bit differently from what we talked about today.
I hope so. It will necessitate that they listen to the entire however many hours we've been on, which I don't think that the same people will be listening to the entire conversation, but let's hope that they do in some way. But anyway, John, always a pleasure, my friend. We're going to do this again, maybe talking more about the clinical outcomes and the clinical process of soft tissue therapy. But perfect. Dr. John Saratsiotis, I thank you, sir.
Thank you.
Okay, talk soon.
Talk soon.